Welcome back to Nursing Research Tips. I'm Jenny Barrow, and today we're tackling one of the most important but often misunderstood concepts in evidence-based practice: levels of evidence. Here's the deal. When you're trying to make a clinical decision based on evidence, it matters the type of evidence that you're using. Some studies are stronger than others, and knowing how to rank and interpret them can help you make better choices for your patients and for your work team. So in this episode, we'll unpack the classic evidence pyramid or evidence hierarchy, give real-world examples, and walk through what makes some evidence more trustworthy or reliable than others. So let's dive in. You've probably seen the phrase levels of evidence, or perhaps you've scrolled past an evidence hierarchy or pyramid in a nursing textbook. But what does this all mean in practical terms? First, think of levels of evidence as a sort of ranking system. It's a way to organize different types of research by how likely they are to give us reliable, applicable answers to our clinical questions. Now, you might be asking, why is this important? And the answer is because not all evidence is created equal. If you've ever taken an in-person research class with me, you know I say that a lot, and it is true. So for sake of consistency, I'm going to repeat myself. Not all evidence is created equally. A blog post from an expert nurse perhaps could be helpful with tips or tricks for your practice, but it does not carry the same weight as a well-conducted randomized controlled trial study. And a randomized controlled trial, as strong as it is, still cannot answer every question, especially questions about patient experiences or ethical dilemmas. Knowing how to evaluate what kind of study you're working with helps you match the right evidence to the right question. And that is at the heart of evidence-based practice. Let's take a closer look at the evidence pyramid or hierarchy, which is one of the most foundational tools in evidence-based practice. Now, I'm about to date myself because the food guide pyramid has not been a thing for quite some time, but think of it like the food guide pyramid, if you even know what I'm talking about. But instead of prioritizing grains or vegetables, it's ranking research based on its reliability, validity, and its usefulness in clinical decision making. So we're going to walk from the bottom up of a typical evidence hierarchy, and I will include examples at each level to help you understand it and to make it stick. If you're listening to this episode in the car and you're driving, or if you're walking on a treadmill, you probably don't have the luxury of looking at an actual evidence hierarchy right in front of you. So I'm going to try to describe it as we go, but think of a typical pyramid. The bottom is much wider, and then it goes into a point like a triangle at the top, which is much narrower. So the base of the pyramid is typically constructed as background information and expert opinions. And this is the starting point for a lot of people, especially students or clinicians who are new to a topic. So what is this background information or expert opinion? It's things like textbooks or clinical practice guidelines, especially without cited research in them. Opinions from experienced professionals or opinions from specialty groups or clinical practice groups like the American Academy of Pediatrics or the Emergency Nurses Association, for example. Also, protocols developed by expert consensus. So here's an example. Your hospital's policy on Foley catheter insertion that was created by an expert panel, but not necessarily backed up by a cited study. This is not bad. There is a place and time for background information and expert opinion, but it's not the strongest type of evidence. Think of this bottom level as an entry point, not a stopping point. Just above the expert opinions on the research hierarchy, moving from the bottom up, comes case reports and case series. These are descriptive studies that are focused on a single patient, that's a case report, or a small group of individuals, a case series. These types of studies have no comparison group. They're just a narrative of what happened. So, for example, a journal publishes a case series on adverse effects of a new medication seen in just a few patients. These are great for highlighting unique, rare, emerging issues that might not yet be formally studied in an official experimental study, but they're new and they can't show cause and effect. On the next row, we have case control studies. These studies compare two groups, one with a condition called a case and one without the condition known as the control. Then researchers look backwards in time or retrospectively to figure out what exposures or characteristics might differ. So let's break that down because that seems a little confusing. First, quick example, a study comparing nurses with carpal tunnel syndrome to those without carpal tunnel syndrome, looking back at their years of exposure to electronic charting systems to see if there might be a linkage between those two things. Another example includes finding a sample of individuals who have medically confirmed diagnoses of lung cancer, that would be the cases, and comparing them to a group of individuals who have never been diagnosed with lung cancer, that's the controls. Researchers doing a case control study, according to this example, would look backwards at potential exposures that might differ between those groups. Common examples might be workplace exposures, smoking habits, exposure to secondhand smoke, etc. These are very useful for rare conditions or outcomes, but they can be prone to recall bias because you're relying on people to remember things that they did years ago. And we all know our memory of what we ate for breakfast this morning might not be the best. So these can be a little tricky with bias. So now as we continue working our way up to the top, toward the top of the pyramid, we see cohort studies. Cohort studies follow two or more groups of people forward in time to see who develops a condition or an outcome. I have a couple of examples for you. First of all, we could do a study that followed two groups of nurses, those who work day shift and those who work night shift. And what we might be interested in is tracking the differences in sleep quality and job satisfaction over the course of a year. For another example from the world of epidemiology, I could enroll a cohort of individuals who work around styrene, a liquid organic compound, to compare them against a cohort of individuals working in manufacturing steel, but that have had no exposure to styrene. I might be interested in comparing those two groups on outcomes related to hearing, auditory hearing, as well as medical data related to heart or pulmonary disease based on previously published studies. Cohort studies are stronger than case control studies because the timeline of exposure to outcome is clearer. Right above cohort studies, we will see typically randomized controlled trials or RCTs. Now we're getting into higher level evidence. In an RCT, participants are randomly assigned to different treatment groups, which reduces bias and improves reliability. These are also sometimes called true experiments. An example, an RCT comparing the effectiveness of two types of central line dressing kits in preventing infection in ICU patients. Now, the key here is randomization. That is what helps ensure differences in outcomes are due to the intervention that is being delivered and not confounding or external factors. RCTs, randomized controlled trials, are excellent, but they're not always feasible, especially in real-world nursing settings with ethical or logistical challenges. Now, one quick note, if researchers perform interventional studies that do not include randomization or they may not have a control group, these studies are typically called non-randomized interventional studies or quasi-experimental studies. These would appear on a lower level of the evidence hierarchy than true experimental studies like randomized controlled trials. At the top of the pyramid, we have synthesized evidence. Synthesized evidence can be things like systematic reviews or meta-analyses. A systematic review is a structured, that's a key word, structured review of all high quality studies on a topic that is evaluated for quality and relevance. This is not the same thing as a basic narrative literature review. This is systematic and structured and most often done by more than one person. Now, a meta-analysis is a specific type of systematic review that combines data from multiple studies statistically to produce a single pooled result. An example would be a meta-analysis examining dozens of randomized controlled trials to determine whether nurse-led discharge education actually reduces hospital readmissions. This type of evidence, this synthesized evidence, is the gold standard for guidelines and policy decisions if the underlying studies are strong. So I just gave you a lot of information. So let's do a quick recap. From the bottom to the top, we have expert opinion and background information, then case reports and case studies, case control studies, cohort studies, non-randomized interventional studies, randomized controlled trials, and lastly, up at the very top, systematic reviews and meta-analyses. Depending on the specific evidence hierarchy you're looking at, you may see qualitative studies on the next to the last row, close to the bottom, right above expert opinions. The reason qualitative studies are typically lower on the hierarchy or missing from hierarchy altogether is because of issues with subjectivity and difficulty replicating or generalizing qualitative findings for the purpose of making practice-based changes. Each level builds on the one before it, and with it comes increased reliability, reduced bias, and greater generalizability. But remember, the best evidence is the one that best fits your clinical question. A perfectly conducted randomized controlled trial is not useful if you are asking a question about patient experiences. In that case, qualitative studies might be exactly what you need. Now, here's the twist. Just because systematic reviews are at the top doesn't mean they're always the best choice for your question. Let me give you an example. Let's say you're exploring how patients cope emotionally after a new cancer diagnosis. Would you want to look for randomized controlled trials? Probably not, because it's probably not going to capture those rich lived experiences. But a qualitative study with in-depth interviews? Perfect. Or maybe you're in a rural health setting trying to reduce falls in elderly patients, but there's no randomized controlled trial or systematic review that fits your exact population. So in that case, a well-designed cohort study or perhaps even expert guidelines might still be incredibly useful. The lesson here, use the pyramid as a guide, not a rule book. Ultimately, you're looking for the best available evidence surrounding your evidence-based practice question. So let's play this out in a few real-world scenarios. Scenario 1, choosing between two wound dressings. Let's say you're looking for the most effective option. Ideally, you want a randomized controlled trial or a systematic review comparing outcomes like healing time and infection rates. Now, what if instead of scenario 1, scenario 2, you're wanting to understand burnout in ICU nurses? Here, you're probably going to lean more into qualitative or mixed method studies that explore experience and meaning and not just numbers. Finally, scenario 3 perhaps finds you designing a new discharge protocol. This is probably going to require a mixture: guideline recommendations, cohort studies, and perhaps even internal quality improvement data from your organization. All of that might be in play. So again, it's about matching the type of evidence to the type of question. Now let's finish with some rapid fire tips. First, start with your question. Refer back to that question often. Don't just chase the highest level of evidence if it does not make sense to your project's question. Next, use leveling tools like Johns Hopkins EBP tools or Melnick and Fineout Overholt's levels of evidence. Also, ask yourself, is this study credible, current, and applicable to my population? And when in doubt, ask a clinical nurse specialist, a librarian, a nursing faculty, or a colleague with research experience. So there you have it. Levels of evidence give us a framework, but context is key. It's not just about what's at the top of the hierarchy. It's about what best fits your clinical question and patient population. So here's your call to action. Go back to an article you've recently read, maybe from class or for a committee project. Try placing that article on the evidence pyramid. Where does it fall? And how confident do you feel in using it to inform care or practice changes? Next week, we're continuing in this theme with an episode called What Makes Evidence Good? We're going to break down internal validity, external validity, and what to look for to determine if research is trustworthy and applicable. Until then, keep asking good questions, keep reading critically, and keep bringing nursing science to life. And as always, thanks for listening to Nursing Research Tips.